My name is Pat Iyer. I have the pleasure of bringing to you Nancy Stuck. Nancy is a legal nurse consultant who has current hands-on experience in the emergency department. Her past experience includes riding helicopters with critically ill patients. And the focus today is on the way that the scene is kept safe and what happens when a patient is brought into the emergency department. By the scene, I'm referring to the scene of the accident. As a legal nurse consultant, you are looking at emergency department records. You could be asked to look at rescue squad records and summarize the details of what went on. And it's all at our level, it's all nice and sterile. It's just paper and ink. It's not nice and sterile when Nancy's involved. Welcome to the show, first of all, Nancy.
Thank you. Glad to be here.
And Nancy is a member of LNC Success Connection, my coaching program to help individuals who are building their LNC businesses to thrive and survive and strengthen their businesses. If we start first about the scene, Nancy, probably everyone who listens to this has been at some point in their life on a highway and watching the traffic slow down in front of them and realizing that something catastrophic has happened on the other side of the highway. That's immediately what I think of when we talk about the scene. And you're driving and you're looking and you're saying, what is that? Tell us about some of the risks that occur when somebody's been catastrophically injured, or it could even be minor injuries. What are the risks about that scene that we should think about?
Well, you pretty much touched on some of it. A lot of it comes from the distracted driver who's trying to go around the scene itself. So you have instances where maybe two cars collide. They may even get over to the side of the road, but police, fire, rescue squads aren't there yet. So it's not sanctioned off anywhere. And distracted drivers look, and then they end up hitting the cars that are on the side of the road or maybe partially in the lane. People may have gotten out of their cars to exchange information, look at the damage that was done, then they're hit. And a lot of it comes down to the distracted drivers who are stopping or slowing down or not slowing down to look at the injuries or to look to see what happened. Mm-hmm. So there's the people who were initially involved in the accident could get hurt again, if they're outside the car. Now they're hit by somebody who's come by. Rescue squads, police, the firemen, they try to set up barriers. That's why you'll see like the police cars or the fire trucks parked at angles. They're trying to create a safety zone. But they've been hit, for the exact same reasons that when the people are going by trying to look, they get distracted and they, veer over a little bit, just enough to hit somebody or something else. Sometimes they hit another car in front of them, creating a second accident.
That innate curiosity that we're talking about can be so destructive in this context.
It does. It does.
Wow.
Yeah.
Are there any other aspects of scene safety that we should think about?
So mostly follow the directions of anybody that's on, in uniform. We've had where when you land a helicopter, the fire department will pick out a safe area for you to land. There's certain qualifications that the landing zone has to have. It has to be a certain size, certain like trees and objects like that have to either be a certain distance away or not above a certain height for the pilots to make the landing safely. If it's at nighttime, it has to be well lit. If it's dirt, like say it's on an old dirt field, you think that would be great. But a lot of times what happens is as the helicopter's landing, the blades are spinning, creating an air speed that's the equivalent of a level 1 hurricane, right? Over 70 miles an hour. So it's blowing anything as it's coming down, it's blowing any loose rocks, dirt out. So it's spraying out at anybody who might be standing there. But in addition, it creates a dust cloud. And so you hope that the fire department will wet down the area first, because there have been times when it's called a brownout. Pilots start to land, the dust literally blows up and covers the entire windshield and they can't see. So from that aspect, the fire department, usually they're well aware of all these things. And so they have to they start out making sure that they're creating as safe of a place as possible to land. But some other things that have happened, and it's again, back to people who are interested in looking, is they'll create a barrier. People will run through that barrier because they want to come and see what's happening, or they want to get next to the helicopter. We have to post, in the past, we would post somebody who's close to the tail rotor of the helicopter. Usually it's somebody from the fire department will like stand, at a certain distance within the half circle of this helicopter tail rotor, because people don't realize it's spinning so fast, you don't even see it. You could walk right into it. So, but we've had people run into the scene thinking, I don't know, they want to get a picture of what's happening or something like that. And they don't realize there's a lot of moving parts on a helicopter besides what's going across the top. So it's a big deal that the rescue people have to be aware of to make it safe for everybody, for the patient, for the helicopter crews, for the other providers on the scene. And like I said, if it's out on a road, that they're trying to make it as safe as they can so that none of them get injured or get hit by a car.
Mm-hmm. As you talk, I have an image of a photo that I saw years ago of a woman who was on a bike who was hit from behind by a bus. And the scene is a photographer. The scene the photographer caught was of another photographer with his back to the person who took the picture, crouching down and taking a picture of the two rescue squad workers, one on each side of the stretcher, and they're walking towards a helicopter. And it's a beautiful summer day and the grass is green, and it's such a contrast with the drama just in that instant, catching them loading the patient towards the helicopter, clearly far away from that rear rotor, but a respectful distance away. Now that you say that the person crouching down taking the picture was nowhere near the helicopter. It was ahead in the scene.
Hopefully outside the barrier walls.
Yeah, hopefully.
They actually had one once where the helicopter was starting to land on Interstate 95, which is, a major thoroughfare. And a semi truck driver didn't see the barrier set up and went right through it. Luckily, the crew in the helicopter saw it happening, yelled at the pilot, and the pilot was able to lift, because if he had continued landing, that tractor trailer would have hit the helicopter on its way down.
Holy cow.
Yeah. So it's a high risk place.
That reminds me of a story my husband told me shortly after we got married. He was coming home at dusk on Route 287 in New Jersey, which is a 3-lane each direction highway. And he said a small plane landed on the highway.
Wow.
And he thought that he was hallucinating. He saw these taillights coming down and he's thinking, what in the world is that? And he was far enough away that he could stop, but never in his lifetime did he envision that he'd be sharing the highway with an airplane.
Yeah, it's the best runway in the world if it's not busy.
If it's not busy and if there's no low bridges made out
Correct.
of stone, which could be a problem, or power lines that might be in the way. I've also thought about securing the scene, Nancy, in terms of something that my father used to terrorize us with kids about: downed electric wires. And don't ever get out of your car if you see a downed electric wire laying on your car, because then you form the contact and you get electrocuted. I would think that wires and active electric wires would also create a hazard for the scene.
It does. And that's actually a true statement, because even though the wire is down on the ground, it can still be live, and you stepping out, you won't even have to step on it. Stepping near it could be enough for you to get an electrical jolt from it. course, it can also cause fires. So where they land something might cause a fire nearby, which now you have a secondary problem going on.
Mhm.
They also cause problems for helicopters when they're not down, because they have to, there have been reports of helicopters that have run into those wires,
Mm.
so they can be very dangerous things, both when they're in the right place and when they're in the wrong place.
Yes. Well, take us now into the ER. We have a person who is being unloaded from an ambulance or a helicopter into the ER bay. And I've been in the Johns Hopkins with my husband when he was having cardiac cath done. I remember being there for about 8 or 9 hours and periodically hearing the sound of the helicopter coming down, and then code 700, or some code that was announced to notify people of the arrival of the helicopter. From inside the emergency department, and we are looking at medical records commonly that say trauma team activated or code trauma activated. What does that mean for us as legal nurse consultants when we're reading those medical records?
So one of the things you can look at is, was the appropriate code activated? In our facility, we have 2 trauma codes, and it's based on what the report that we get from EMS and the symptoms or the severity of the injury that the patient has. So if they're stable, their injuries don't involve like their head, or they're not bleeding and they have good blood pressure and everything like that, we would call one type of a trauma code. If they're very unstable, if they're unresponsive, if they're not breathing, anything like that, we would call a different level. So you would want to look and see what levels of activation was done at that hospital, and was it the appropriate level. Although you do have to understand that it's based on the report that's given, and sometimes the patient condition changes after the report's given, and you just have to recognize that as soon as that person comes in, you have to change the level of the code that's put out. So it's not all, I'm not saying it's always the fault of the people calling it. There's a lot of moving pieces that go into it, but look at the type of code. Is there more than one code that can be activated? And then who responds to that code? For example, when we call one of the people, when people are stable and we call one type of trauma code, it's the trauma team, mostly residents, nurse practitioners, the nurses who show up. If we call the more severe trauma code, the trauma attending and the ER team comes over, and there are airway providers.
Mhm.
So if the appropriate people, was it called so the appropriate people for that level of injury was there? And if not, did they get there quickly? Was it recognized soon that the inappropriate code was called, or it wasn't inappropriate, it was appropriate for that at the time being, but if there's a change, how quickly did they call the more severe code? If there was a secondary type they call, and how quickly did the people respond? So you look at arrival time, and then arrival time of each of the main providers.
Given all of the things that have to be assessed, one of the arguments that we deal with as legal nurse consultants is, I was so busy taking care of the patient, I didn't have a chance to document. Patient care comes first.
Right.
And unfortunately, that is true.
Mhm.
And trying to figure out after the fact what happened is complicated by all of those missing pieces of information.
Correct.
With the rapidity of actions in the ER, what documentation pieces should we be looking for, or what systems should we be looking for that would enable people to do quick checkoffs versus having to write a lot in the midst of this?
So that's been actually a little bit of a controversy that has gone on for years. We actually still use paper documentation. The whole hospital is EMRs, right? We do a few things in the EMR, but we do most of ours on paper. So you have to look at what system they have. And is any part of that documentation done separately? You know, that our paper records do get scanned in, so they do become part of the medical record within the computer. But you can look and see what type of system they have. And is there other documentation that's not included actually in the computerized records themselves? You always want to look at the vital signs. That's going to tell you a lot of information. However, it might not give you the full picture because, you know, we've even had patients, families say this, like the pulse ox, it looks like it's low. Well, it is, but it takes somebody to look at it and realize, well, the waveform is completely flat and it says that the patient's heart rate is 20 and the patient's heart rate is really 98. So you know that's an inaccurate reading. But sometimes with computerized systems, that gets recorded anyway. So it looks like the pulse ox was low and it wasn't, or vice versa can happen. So you have to also look at the entire picture, what else was going on to help. Does everything make sense? Is this one vital sign really abnormal if everything else is normal? Or was it perhaps there was something wrong with that vital sign or the way they were checking that vital sign?
One of the things that I've discovered in a case that I've been working on is that in order to save the patient data on a vital sign monitor, depending upon the brand,
Mhm.
the patient's name needs to be entered into the monitor when it's turned on and attached to that patient.
Right.
And if it is cleared or turned off without the patient's name having been entered, then the data gets wiped out and
Right.
there's no way to retrieve it.
Right.
And that becomes an issue in certain types of cases. I'm thinking of, this is also a prime temptation in an emergency department. Get that patient in, get them hooked up with their leads, get them attached to the vital sign monitor. But did they take the time to put the patient's name in? And
Sure.
does that data simply disappear when the patient's taken off of that monitor?
Right. So ours in the emergency room, like I said, it doesn't get associated with a name at all. The good thing, so on one hand, that seems bad because, you know, I know upstairs on the floor, because I also do rapid response, and we ask them to, you can scan the patient's ID bracelet and then with a wand, and it then connects that Dynamap to the patient's record. And that's all good, but when a patient first comes on, they don't have a arm bracelet, right? When they're first coming in, it takes a few minutes to get them registered.
Yep.
So we have our monitors, we've already have them on monitors. We're already checking vital signs. Patients sometimes, you know, you never know what's going to happen to the way that they have to register the patient. Sometimes there's a delay in that computer. So we've had patients might be there 5 or 10 minutes before we have an arm bracelet for them. So we can't wait
Mm-hmm.
to do vital signs and everything, just waiting for the arm bracelet so that we could connect the machine to this particular patient.
Mm-hmm.
Then when it's very busy, which it is in a lot of emergency rooms now, this patient has become stabilized, but your next person's coming in, you're quickly taking that off the stable person, cleaning it very quickly and putting it on the new person. And if you haven't changed the name there, now you have vital signs for this new person might still be connected to the old person's name. So it can be a tricky situation
Mm-hmm.
for the nurses to make sure that they have it correctly correlating with the correct patient.
Yes. Yep. I can see how that could happen.
Mhm.
We've got a person in the emergency room. I'm going to bring you back down to that ER. A little nuance. I learned several years ago, it's an emergency department. It's not an emergency room. The emergency room language is archaic because
Right.
rarely do you have a hospital with a single room
Right.
compared to a department.
Mhm.
I have heard of people whose chests have been opened in the emergency department for emergency thoracostomies before rushing them into the operating room. Tell us about what is that like?
So unfortunately, this area I work in the emergency room is for the traumas and the burns. I would say we open a person's chest at least once a week. Sometimes we'll open, I've had in one day, in fact, I've even had 2 patients with their chests open at the same time. Get several people from the same accident, sometimes completely different things. And the trauma team is going back and forth, opening both people's chests. It's an intense situation, and you have to really focus on what's happening. The person has lost their blood pressure, they've lost their pulse, they're unresponsive. Hopefully, they've been intubated, but sometimes that surgeon is already opening the chest while somebody else is trying to intubate the patient. Once they get it open, they're sucking out, the bloody fluids, trying to find, usually when you open a chest, it's usually from a penetrating wound. It's more rare to open a blunt trauma like a car accident, a fall. There are times when they will choose to open the chest, but it's not as often as a penetrating wound, such as a knife or a bullet. So what they're doing is they're looking for the hole, or they're looking what happened inside. They're literally looking inside the chest. What do we see in here? Where's the blood coming from? What can we temporarily put a couple of stitches in, put something, a clamp, we cross clamp the aorta all the time, trying to find where the bleeding is coming from to get them to the operating room. Once you open the left side of the chest, there's a couple ways they can do it. They can either cut through the ribs on the left side chest. Sometimes it's very rare that they go down this way, like they go straight down the sternum like they would for open heart surgery. That's a more controlled environment in the operating room. So they're literally just going in, they're trying to see the heart, that aorta, all the pieces right there to see, can they see a hole? If not, now they have to open the right side of the chest. Again, looking, is there holes on that side? Minimally, they're going to put in a chest tube on the right side to see if there's blood coming out of the right side of the chest. If there is, now again, they have to open the right side to see, is there a hole there that they can attach? During this time, obviously they don't have vital signs, but we just opened somebody's chest, what day did I work? Saturday. And they did internal compressions, and then the person went into ventricular fibrillation. So you have to put the internal paddles on the defibrillator, and you put the paddles right on the heart itself and defibrillated the patient.
Now that's dramatic, Nancy.
It is. And
that's not something I've ever seen.
We do it. I've done internal chest compressions. There, you have to be able to, you can't squeeze it like this because the chance of your thumb going through the ventricle is high. So you have to do this kind of like this motion, and more like this actually. And you're squeezing, you literally have the heart in your hands and you're squeezing like this to try to give it the internal chest compressions while they figure out where the bleeding's coming from and trying to repair a hole.
Have you seen people survive after having internal chest compressions?
Mm-hmm. Quite a bit. It's all based, what a lot of it's based on is timing. How soon did that person get to us? And then when did the pulse, so the kind of the guidelines for American College of Surgeons is 15 minutes without a pulse. You can still open a chest 15 minutes. If they've been without a pulse for 15 minutes for a penetrating wound, I think it's 15, maybe a couple minutes more than that, but only like 10 to 12 minutes for a blunt. Again, because of the type of injury that you're going to find, they give a little bit longer because it's something they can readily fix if it's from a penetrating wound. We take quite a few. That last person I did take down to the operating room. People have walked out after that. We had a little young kid, firefighter, first day on the job. So I think he was, I don't know if he's 19, 20, 21, that age range. He was standing in front of a fire truck, and another fire truck didn't see him and backed into him and squished him between the two fire trucks. They brought him in, were doing CPR, they opened the chest, they couldn't find injury. And like I said, that's a blunt injury, but he was close enough that they chose to open anyway. The surgeon actually cut away part of the lung right there and got the pulse back. He created the issue. He created the problem he solved the problem with the left lung that allowed the blood pressure to come back and got him to the operating room. That kid walked out. Mm-hmm.
I think about all the meticulous dissection and the cautery and the draping and the cleaning that goes on in a regular OR. Is this procedure that you're describing, opening the chest, is that done without including any of those pieces that I've just described?
We usually throw betadine all over the chest. Draping is depending on what's going on. Usually they don't have time to do draping. It's you squirt betadine all over the chest, try to get the skin a little bit clean, and that scalpel is cutting through immediately. You don't have time to I mean, they still have to look for, if we're putting lap pads in, especially if we open the belly at the same time and you're packing. We have radiopaque lap pads so that they can be shown on x-ray. But we don't necessarily count them. We try to, but we don't necessarily count them before they're being pushed in because they're literally just being shoved in as quickly as possible.
Right. Right. And then that would become the responsibility of the OR staff to remove
Correct.
all that at the end of the surgery.
Correct.
Yeah, I've seen count sheets. One of the interesting things about OR cases when there's retained sponges is the count sheet correct? Was it done at all? And in the situations that you're talking about, I've seen statements that say count sheet not completed due to emergency.
Right.
But in other cases, the count sheet is invariably correct, even though there is a sponge left behind or an instrument left behind. We kind of cynically laugh in legal nurse consulting of, yeah, well, if the count sheet was not correct, we wouldn't have this case because they would have figured out that something was missing, done the x-rays, pulled it out of the patient's belly. Sometimes it's a towel also.
Right.
Surgeons grab towels from the Mayo table and shove them into the abdomen and tuck them away in a quarter. And because it's not part of the count sheet, well, they go off to the recovery room with the towel still inside. But I digress. Your description is pretty amazing, Nancy. If I think about somebody standing in the ER, watching that type of opening up of the chest in an emergency, somebody's laying there and their clothes, there's not draping, it's just fresh, off the cuff surgery.
That's exactly it. We cut away the clothes, try to avoid any bullet holes or stab holes in the clothing, cut around that, but you try to get that open as much as possible. And then, like I said, squirt the betadine on the chest and they're immediately inside.
Any final tips for our legal nurse consultants who are involved in looking at emergency department records when there is this type of significant trauma that we've been talking about?
So for this particular type of emergency trauma, it's going to be, again, well, hopefully by this time, but the case that they've triaged to the appropriate place. But you can't, if weather is a factor or something like that, sometimes they go to the nearest hospital first and then get transferred to us. So you look at that decision. Why was that decision made? Who made that decision? Once they're in the level 1 emergency room, hopefully, again, you look at what type of code was called, who showed up, what's the timing of the people who showed up, was anybody delayed for any reason? And then look at the notes. The notes sometimes, unfortunately, a lot of newer nurses don't write as much narrative notes as they used to because everything can be filled in. But in an emergency department, there's a lot that, no matter what type of system you come up with, there's not a good checklist that's going to cover everything that happened. So you'll find that sometimes the emergency nurses are writing more narrative notes, and look at the narrative notes to see if it tells the story of what happened. And sometimes you can compare it to the provider's notes. Did they match? Do not only the times match, but does the description of what happened, do those match? Do the nurse's notes match with the physician's notes?
Yes, and that's one of the ways that legal nurse consultants can prove their value to attorneys, is that detail-oriented mind to be able to pick up on those discrepancies. Nancy, I know that our listener is going to want to know how to reach you, to discuss your services, what you can do to assist in the analysis of ER cases, trauma cases. What would be the best way for that connection to take place?
I am on LinkedIn, but my email address is nlstuck, so NLSTUCK, the number 3 @gmail.com.
nlstuck3@gmail.com.
Yes.
Thank you so much, Nancy. I am in awe, quite honestly, of what it takes to go and walk into the hospital in your shoes and assist with those trauma cases when life is hanging in the balance.
Mhm.
And
Thank
that
you.
person's life's in the hands of capable, critically thinking, skilled practitioners who are trying to juggle multiple competing priorities.
Right. Thank you.
Thank you so much for being a guest on Legal Nurse Podcast. For you who's been listening to the show, go to the Apple Store and get the app Expert Edu. That's EXPERT Edu, EDU, which is our app for legal nurse consultants and for people interested in writing smoothly for their businesses. You can get that from the Apple App Store, and you can also get it from Google Play if you have an Android phone. You'll get updated with blogs, with videos, with podcasts, with tips that will help you, whether you're a legal nurse consultant or you're interested in writing, or maybe both. Come back next week for a new show, new guest, and thank you for spending your time with us today. Bye-bye.
Bye.
My name is Pat Iyer. This is Legal Nurse Podcast and a recap of what is going to be coming up next in the next Legal Nurse Podcast featuring Nancy Stuck, who currently works in an emergency department, also works as a legal nurse consultant, and has in the past been one of those people in those medical helicopters going to the scene and bringing seriously injured people to emergency departments. We just finished our podcast recording and wanted to give you a taste of what Nancy covers. Nancy, let's just mention a couple of the topics that we went into in your podcast so that our listener knows what's in store for them.
So we talked about scene safety, what to expect of as they're setting up if there's been an accident. And then we talked about look when a patient actually comes into the emergency room as a severe trauma, and give tips about what legal nurse consultants can look at in the chart as that patient was taken care of during their time in the emergency room.
We covered a lot of territory. One of the things that I know you are going to walk away from is Nancy's descriptions about how people's chests are opened in the emergency department, which happens in her world at least once a week. You'll have to listen to her podcast to find out what that's like, what you might expect to see in the medical documentation in severe trauma cases. Be sure to tune in to Legal Nurse Podcast and Nancy Stuck's show. Thanks.